afternoon and welcome back, ladies and gentlemen. I welcome you to the next symposium of the day titled Psychiatry for Physicians. I'm delighted to introduce our chairpersons for the session, Dr. Chamara Wijesinghe, Consultant Psychiatrist, National Institute of Mental Health, and Dr. Prabhashini Kumarihami, Consultant Physician, Base Hospital, Kahawata. They will both now lead us through the sessions. Over to you both.
Good afternoon and welcome to the session on mental health and medicine, and we will explore the interactions between mental health and medicine. Some years we don't have a mental health symposium in the CCP sessions, but this year the president did not have any choice, he had to have one. So without any further ado, now I would like to ask my colleague to introduce the first speaker.
Okay, our first speaker is Dr. Chathurie Suraweera. She is talking about the managing psychiatric disorders in non-psychiatric setting. And Dr. Suraweera is a senior lecturer and head of the Department of Psychiatry, Faculty of Medicine, University of Colombo, and she is also a consultant psychiatrist at the National Hospital, Sri Lanka. So over to you, Dr. Chathurie Suraweera.
Thank you very much, and thank you for the Council of the Ceylon College of Physicians for the opportunity. Most of the time, when it comes to other specialties, we know at least something about managing the emergencies, which are not so common. But we can actually increase the well-being of most of the patients by treating the common ones, which might be related to another specialty. So here, in my short speech today, I'm going to concentrate how we can do that in the non-psychiatric setting, which is, in your case, the medical wards, how we can manage psychiatric conditions. So there is an increasing burden of psychiatric disorders globally and a shortage of psychiatrists. So the role of non-psychiatrists in the management of mental health issues is becoming more and more. This is very much applicable to Sri Lanka because we are losing psychiatrists at a very high rate. 1 in 4 people globally will experience a mental health issue in their lifestyle. And because of that, there's a huge burden on healthcare settings. And along with that, with the strokes, with diabetes, with all the medical and surgical issues, the comorbidity of mental illnesses is also increasing. So what are the challenges that you would come across with regards to psychiatric conditions in the medical setting? Sometimes there is difficulty recognizing psychiatric symptoms because most patients will come into medical wards with symptoms like vertigo, headache. They won't come and tell you that they are having depression. And sometimes they might come and tell you that I'm not opening my bowels. If you don't ask the next question whether you think that your bowels are blocked, you won't recognize the nihilistic delusion, but actually treat for a constipation. And in this part of the world, we are not very good at expressing our emotions. So therefore, they might not come and tell you that I'm feeling bad, I'm feeling sad, I'm feeling depressed. Instead, they would come and tell you, I'm having a headache, I'm having a backache, and so on. So that will have to alarm you or alert you to think of psychiatric conditions. And you have to recognize, detect, then we psychiatrists expect you to manage some of the psychiatric conditions in the medical setting because the burden is huge. So when managing a possible psychiatric condition, we have to think of whether the diagnosis is right. For example, just because a patient comes to you with a paracetamol overdose, that doesn't mean that the patient is depressed. And are there any risks? Is the patient agitated? Is the patient still having suicidal ideas? Because sometimes we might think that taking 50 tablets of paracetamol is a huge risk, but the patient may have taken it just to scare somebody off, which means the psychiatry-wise, the risk is not so high. But if the patient took 5 paracetamols but still wants to die and thought that was lethal enough to kill him, then psychiatry-wise, we have to pay more attention. Make sure that the grills are on, the windows are closed, because that's the patient, psychiatric-wise, would be more risky. And then diagnosis as an assessment. I know it takes a lot of time to go through the assessment, but especially in the setting of stroke units and epilepsy units where the psychiatric comorbidities are high, it might be worthwhile to administer some validated tools, because in Sri Lanka there are Sinhala validated tools. So routinely, because we know that the rates of depression is high among post-stroke patients, perhaps as a routine you could administer that. And in diabetic clinics. And we have to be mindful, the quality of life in most of the patients with chronic illnesses goes down, sometimes not because of the medical illness, but because of the depression or the anxiety that they're having, which may be because of the medications that the patient is on. Or which may be because of the disease itself, like for example, hypothyroidism causing depression. So, with that in mind, let's go through these case scenarios. I won't give you the answers. Hopefully by the end of this presentation, you will know the answers. Right. I hope you're not feeling like this. So, first, let's move on to a very common condition, which is often missed. Adjustment disorders and depression. Why do we need to know this? Because adjustment disorders, we don't have to start any medication. Just an anxiolytic might do, whereas depression, we can't miss it. And it's so common among the patients who are medically ill, particularly when there is diabetes and so on. And there is underdiagnosis and undertreatment, and perhaps not with the right treatment as well. So, in order to diagnose a depressive episode, you will see that having suicidal ideas is not an important criterion, whereas depressed mood, marked diminished interest or anhedonia is very important. And if there is functional impairment over a period of time, that's depression. And importantly, these patients would not come and tell you, I'm feeling sad. They would come and tell you, I'm having heaviness of the head, I have poor sleep, which if you don't really dig into the history, you will only give a benzodiazepine and the patient will end up having depression as well as benzodiazepine dependence. And when there are more gradual exposure to life stressors, like for example, divorce or unemployment, or having been detected with diabetes or a cancer, that's an adjustment disorder. And when the stressor is removed and when the patient is getting accustomed to the new life, they feel better. They might feel sad, but they would not fit into the criteria which I mentioned earlier. So it's not depression. We don't have to start antidepressants here. Another very important one, anxiety disorders. And what is that? It's very prevalent in high prevalence in ICU and HDU settings, and it impacts the recovery and rehabilitations, and it can easily be sorted out. That's the important thing. Patients do not have to suffer, and the patient engagement will be less if you don't pay attention. And how do you differentiate? Let's imagine there's a dog in front of you, and what you feel, it's the fight or flight mechanism. If you're feeling the fight or flight mechanism, the symptoms of worry, apprehension, sympathetic symptoms, features of muscle tension, all the time, almost throughout the day, then that's generalized anxiety disorder, where there is free-floating anxiety. But if that is happening sporadically, like, just without a stimulus here and there, those are panic attacks, which can most of the time mimic sometimes angina or sometimes bronchial asthma. There have been instances where patients have been put to ICU. And phobic disorders. For a phobic disorder, the easiest way to differentiate is there is a stimulus like a dog or a butterfly or a height. So it will be like this. Fight or flight most of the time, generalized anxiety disorder, sometimes panic attacks without a stimulus, and if it is with a stimulus, a person or a place, it's a phobic disorder. This is a very important section. How do we use antidepressants? Well, because if we diagnose a patient with generalized anxiety disorder or depression, the treatment is antidepressants. But for mild depression, adjustment disorders, acute stress, there is no indication to start. Just because a patient is feeling sad, you don't have to start an antidepressant. Because if you do start an antidepressant, you have to, if it is the first episode, you have to continue it for at least 6 months. Antidepressants are recommended for moderate to severe depression and dysthymia, and selective serotonin reuptake inhibitors are the first line. I thought I would talk a little bit about antidepressants because I know it's very commonly used in the medical settings. Going beyond fluoxetine, now there are several antidepressants which are in the market. Fluoxetine, sertraline, those are available in the government sector. Venlafaxine is available in the government sector. There are the tricyclic antidepressants and the drugs like mirtazapine. And these are the starting doses which I have mentioned. Because it's important that we give the proper doses. Because, for example, if we take the tricyclic antidepressant amitriptyline, we often see patients on 12.5 milligrams of amitriptyline, which is mostly used for sleep. But if the patient is having depression, that dose has to go up to about 100 to 150. And if it is due to pain symptoms and this patient is having depression as well, and if you are unable to increase the amitriptyline to 100 and 150 because of the sleep issues, perhaps you could go for something like venlafaxine, which is also good for pain and depression and severe depression at that. However, although duloxetine is good for pain, it's not that effective in severe depression, which we have to keep in mind, because sometimes it's better to tail off duloxetine and put the patient on venlafaxine if there is severe depression as well. So something that we forget, yes, SSRIs are better tolerated, but there is gastrointestinal bleeding. Just to remind ourselves, I have put the figures. So if you are starting a patient who is on aspirin and is on SSRI, you have to add a proton pump inhibitor. And drug interactions, we have to be very cautious. We can't remember, obviously, but then the drug interactions can be checked easily. So I have checked this for you, escitalopram and azithromycin. So these are the interactions. Sometimes we do make such mistakes, haven't we? And of course, all psychotropics like antidepressants and antipsychotics can lead to hyponatremia. And hyponatremia looks very much similar to the depression. So if you go and increase the antidepressant dose, the hyponatremia might get worse. I have mentioned some interactions. By the way, I have seen patients on fluoxamine and tamoxifen together. So this is what happens. And going beyond fluoxetine, as I mentioned earlier, now there are medications, antidepressants, which can be used very specifically with evidence. Like, for example, post-stroke depression, post-myocardial depression, sertraline, mirtazapine might be better than fluoxetine because fluoxetine is having a long half-life, roughly about 3 weeks. So if there are interactions, there might be issues there. Then sertraline, citalopram, these drugs are better for hepatic and renal conditions. Again, because of the same reason, fluoxetine has a half-life, longer half-life. Moving on from depression, delirium, dementia, and psychosis. How do we differentiate the two? In the medical setting, sometimes there are very, very difficult patients. Delirium is acute, hours to weeks, and alertness is abnormal, sleep-wake cycle disrupted, orientation is not there. Whereas in dementia, the cognitive impairment is long-term, and there would be delirium at times, but there would be an acute change in the background of this chronic change. Psychosis, no disorientation, and the delusions and hallucinations will be very well formed. Whereas in delirium, it's not. And in dementia, psychosis comes at a later stage. When we prescribe antipsychotics, it could be delirium, it could be dementia or psychosis. It's for delusions, hallucinations, and agitation. And we have to start with the lowest possible dose. We can't give 65-year-old, very elderly person 10 milligrams of IM haloperidol. We have to start it with 2.5. Yes, she might not respond, but it's better to go that way because the patient might start to show the reactions the day after. And we are running short of benztropine vials these days, so you might not be able to tackle the problem, particularly because benztropine vials are only available in the government sector. And for the NHSL, at one time, there might be about 4 or 5 vials, only at Ward 59, the university unit. And half the dose for elderly, otherwise they might not tolerate it. And for the management of acute agitation, IV haloperidol is no longer recommended. It can be given, but no longer recommended. It's intramuscular, which is recommended. And it's HC to be administered to an agitated patient as well. Otherwise, you have to look for a cannula. When it comes to the use of antipsychotics in delirium, the mainstay of managing delirium is correcting the cause. It's just a psychiatric manifestation of an organic illness. And if the patient is not having any issues, a risk to self or to the others, and if the patient is allowing interventions to be done on the patient, there is no indication for an antipsychotic at all. And also, benzodiazepine should not be given because it worsens the delirium, except in delirium tremens, because there is a need for benzodiazepine in that situation. And of course, if the patient is in hepatic failure, it's better to give lorazepam, but the problem is now we have run out of lorazepam. So, and it's okay, delirium can last for about weeks in elderly people. So we have to be patient, not to load the patient with medications. And if a patient is having undisturbed psychosis or hypoactive delirium, which might mimic depression, you don't have to give anything. And you may use olanzapine, which has evidence for a patient who has sleep-wake cycle disturbances. So let's go back to the scenarios which I mentioned earlier and whether we can get the answers right. Did you get this answer? A lot of somatic symptoms in this patient. So somatic symptoms, depression, venlafaxine is better. Amitriptyline 12.5 will resolve the sleep issue, but then the issue is that's not enough. You might have to titrate up to about 100 or 150. And the sedative effect is very, very bad. But if you do not think of depression here, you might actually treat the patient for heaviness of head or dizziness and poor sleep, alprazolam, so the answer might be C, and patient will be having the depression for a long, long time. So it's venlafaxine. This one. Usually, the important thing in patients with panic attacks is that they get this fear of dying, and it comes out of nowhere. And if you really inquire into the history, there might be a background issue, a stressor going on. They might not be able to correlate it with the stressor, but it will be there. Then the scenario 3. This is actually a hypoactive delirium, a common condition that is missed, and a common condition that is treated as depression. But hypoactive delirium is most of the time due to metabolic causes, and the morbidity, mortality would be high if not treated fast, because we don't miss hyperactive delirium usually. And then, what is the most appropriate medication? None. So in my presentation today, I was trying to highlight the importance of detecting the psychiatric illnesses and some cautions and indications for antidepressants and antipsychotics, and the need to be alert to these symptoms. Thank you.
Thank you, Dr. Chathurie Suraweera, for your informative lecture. And so my co-chair will introduce the next speaker.
The next lecture is on psychosomatic disorders, psychiatric disorders masquerading as medical disorders. And the lecturer is Dr. Chamara Wijesinghe. Dr. Chamara Wijesinghe, MBBS Colombo, MD Psych Colombo, and MRC Psych UK. He's a senior lecturer at the Faculty of Medicine, University of Kelaniya. He's the current editor of the Sri Lanka Journal of Psychiatrist and member of the Board of Study in Psychiatry and honorary consultant psychiatrist to Mal Madura. He's also a member of the medical panel of Sri Lanka Cricket. In fact, he's the official psychiatrist to the Sri Lanka cricket team. So he himself was a well-known sportsman, a rugby player in his school days, and a national tennis player. So with over 15 years of experience working in liaison psychiatry as a consultant psychiatrist at Ragama, which is one of the largest tertiary care hospitals, Dr. Wijesinghe brings a wealth of experience in managing patients with psychosomatic conditions and is well positioned to speak on this topic. Over to you, Dr. Wijesinghe.
Thank you, Sajivana. Thank you very much, Dr. Upul Dissanayake and the CCP for inviting me. It's a great honor, and especially to have Dr. Anandaraja, whom I did my internship 20 years ago in the audience. It's very nice to speak in front of you, sir. All right, so moving on, these are some excerpts from BHT seen at Ragama, right? So the moment the patient comes, the HO clerks the patient as the presenting complaint is multiple somatic complaints plus, right? The moment you start the process like that, the patient is in a losing battle, right? Stigma has started. Another patient, a registrar comes and says, doesn't fit with a neurological weakness, query malingering. Query, you are a liar, right? Another patient, SR says, psychosomatic discharge. I mean, it's a busy ward, you have to clear the beds, but these patients are not getting a good deal. The physician sees a patient, functional, a very old term, functional as opposed to organic. Organic is what we do, functional, we don't deal with you, psych referral discharge. So this is the sort of groundwork these patients present with. And once you present like this, certain emotions are brought up by the medical team. The medical team is a busy team. It is a difficult unit, right? You are treating a patient with myocardial infarction. There is a dengue leakage going on, and suddenly you have this patient who has these symptoms. The team is annoyed, right? You are angry. They are dismissive. The whole group, consultant SR, the round is going. They are at a bed. Then you're waiting for to be seen. You move along at that bed, not even 5 seconds. You are having problems, you're not treated well at home, you feel you're avoided, not neglected by your family. You come to a place of respite for help and you are neglected here as well. There is cynicism, and these are felt by people. We know when people don't like us. We know when people are not respectful of us. The patient censors it. They are ridiculed. The jokes are loud now, psycho patient kenek, right? There is mistrust, right? Me boru karanne, right? And there is also confusion. What do you do with this person, right? So let's look at how to deal with this confusion in a patient coming with medically unexplained symptoms. So you have a patient, the symptoms are there, but it does not fit into our category, our diagnostic formulation. So the first thing you do is, as my colleague Chathurie mentioned, look for depression. Right? Are they sad? Are they not eating? Are they sleeping? Has there been a problem in their family? Then the management is for depression. Are they anxious? Right? Is their heart beating fast? Are there prominent autonomic symptoms? Right? Is it in reaction to a fear? Then you deal with anxiety. Right? Then you get a group of people who are not depressed, not anxious, but coming with medically unexplained symptoms. They will fall into 4 categories. One will be somatization disorder, somatoform disorders. There will be another group who have hypochondriasis. We will talk about the differences of this as we go along. Then you will get patients with conversion or dissociative disorder, and there will be a certain group of people who are malingering. So this is the sort of framework you work on. Now, to figure out which one of the 4 in the right it is, you need to go back to the patient, not the symptoms, and see what is the patient focusing on. The patient's focus is what is important, not our diagnosis or the symptom. So all 4 patients will have the same symptom of headache. You look at what is their focus. So the patient who somatizes, their focus is on the symptoms. They are coming with these symptoms, backache, headache, gastric symptoms. They are worried about the symptoms and want help with alleviating the symptoms. Then you get the hypochondriasis patient, has symptoms, but his or her focus is the diagnosis. I have something seriously wrong with me. The conversion or the dissociation person is coming with a disability, right? They cannot walk or talk, they can't do anything. Whereas the patient malingering will be looking for some benefit to get out of an exam, to get out of a court case, right? Or some insurance matter, right? So always see what is the focus. Don't just put it as psychosomatic, functional, and that is that. Start an antidepressant and send. Each patient will be different. So I'll go through some patients. I actually for this got real patients. Then I thought, the patients consented also and said, we are very happy to help, somebody can learn. Then I thought, now physicians will see this, and this patient, psychiatry video the patient will get a really bad deal, so we got actors to help with us. This is the actual thing the patient said.
endoscopy එකක් කරලා මට බෙහෙත් දුන්නා. ඒ වෙලාවේ කිව්වේ මුකුත් ප්‍රශ්නයක් නැහැ. නම් බෙහෙත් දුන්නා නේ බෙහෙත් දෙන්න පාවිච්චි කරන්නේ නැහැ. ඉතින් එනවා ඒ වුණාට. ඊට අමතරව ඊට කලින් වෙන මොන හරි අවුලක් එකමාරකට දෙහෙදෙක ඉස්සෙල්ලා මේ මට ෆෝන් එකක් කරනවා. මට ගෙදර වැඩ කරගන්න නැති අවස්ථාවක්වත් වුණා. මේ ගෙදර වැඩ අනිත් හැදලේ. ඒ වෙලාවේ මම ඩොක්ටර් කෙනෙකුට පෙන්නුවාම එක්ස්රේ එකක් එහෙම ගත්තා. බ්ලඩ් රිපෝට් එකක් ගත්තා. ඒකක්වත් මුකුත් ගැටලුවක් නැහැ කිව්වා. ඒ වෙලාවේ විතරනාකගේ බෙහෙත් දුන්නා. එච්චරයි.
Okay. So you will see that the patient has multiple symptoms over a long period of time. The ICD-11 mentions it as disorders of bodily stress, a syndrome of chronic multiple somatic complaints without an identified organic cause. They are distressing. There's repeated care with healthcare providers. The ICD-11 doesn't mention it as diagnostic criteria, but what will be useful is our patients will always have done an MRI or a CT scan in the private sector and will have a large plastic bag, and inside that bag there will be loads of clinic books. Moment you put that on the table, you know, okay, chapter finish, match over, right? So it's a very, very distressing thing. Multiple organ systems are involved, and these cannot be described by anything. There's significant functional impairment, and usually there are psychosocial stresses underlying. So what do you do? How do you manage this, right? The first thing is, what a lot of these patients get is, you are okay. There's nothing wrong with you. What a ledak naha, then hari. Now this is very distressing for the patient. They have a splitting headache, and the specialist is saying you're okay. And they're like, how can you say you're okay? I have the headache, right? You have no right to say this. So automatically they go, either they come back or they go to someone else. Just us saying somebody, you have nothing wrong with you, when they are suffering, doesn't take away the suffering. So you provide a positive diagnosis. What a positive diagnosis is, you say, we investigated your headache. අපි පරීක්ෂණ කරා, බැලුවා, ටෙස්ට් කරා. මේක මත ඔයාට ලොකු ලෙඩක් නැහැ. ඔළුවේ ගෙඩියක් හරි ලොකු බය වෙන්න ඕනේ ලෙඩක් නැහැ. Right? And they are reassured. හැබැයි then you move in to a explanation. හැබැයි ඔයාගේ ඔළුවේ කැක්කුම තියෙනවා. මට ඒක තේරෙනවා ඔයගලන්ට ඔයාට ගොඩක් අමාරුයි කියලා. Right? So now you have reassured them. You have told them you don't have anything serious, and you are acknowledging their headache. You are not saying you don't have a headache. You don't have the right to do that. And this is distressing your work, your school work, your homework. We will help you with these things. And then you change the narrative to, there are certain conditions which can come without having a serious physical illness due to psychological reasons, right? When I studied for exams, I used to get headaches. The same way, I didn't have a brain problem, but the stress of the exam. What are the stresses in your life, right? And the patient is more open to this dialogue. And you develop a contract with the patient, and you attend to these symptoms, looking at the biopsychosocial approach. So they will have various things which need a bit of treatment. So simple analgesic, proton pump inhibitors, whatever. You can add a bit of medicine to hold the patient. Look at the psychological aspect. If you see this patient, she's not depressed, she's well-preserved, smiles, and help with them social things. You create a contract with the patient, targeting early symptom reduction, and try to avoid emergency presentations. Going from place to place is the difficult thing. So you will give them a date to come. Providing them, that is very important. If not, you just send them, they will go somewhere else. Creating a single point of access is the most difficult thing. In Sri Lanka, you can go anywhere. If you're in a developed country, you have to go to your GP. The GP knows how many CT scans, ECGs you have done. So try to create that either with yourself, with a GP, with a physician, with a clinic, and say, if needed, we will refer. We will see you in 1 month, in 2 weeks. Regular reviews are needed because they are anxious. Help them with their psychological stresses. If comorbid depression is there, they will benefit from antidepressants too. So you're giving a more holistic package for the patient with somatization. This is another patient.
Good morning.
Good morning, doctor.
Bye, Namaste.
I'm driving to the පරීක්ෂණයමත් කරා මේ අන්තිමට කරේ CT පරීක්ෂණ. CT පරීක්ෂණය දැන් සති දෙකක් විතර කලින් තමයි කරේ. ඒකෙන් මොකද කියන්නේ? ඒකෙන් කියන්නේ මොකුත් නැහැ. ඊට පස්සේ කොහොමද? ඊට පස්සේ අපි CT එක කරලා මොකුත් නැහැ ඒකත් මට පොඩ්ඩක් තිබ්බ දවස් දෙක තුනක් තිබ්බ හොඳ වෙලා වගේ. ඊට පස්සේ ආයෙ ආවුයි. දැන් එතකොට MRI එකක් කරන්නේ ඉතින් සාමාන්‍යයෙන් මම ඩොක්ටර් ඊට පස්සේ දැන් ආවහින්න බැලුවා පොඩ්ඩක් ඔයලා Google එකෙන් මේ බැලුවා මේ CT පරීක්ෂණය. ඒ වගේ 90ක් විතර මේ කියන්න පුළුවන් හරියට 90ක් මොනවා කියන්නේ මේ මොන හරි රෝගයක් තියෙනවා නම් හරියට කියන්න පුළුවන් 90ක් විතර. ඒ හින්දා මම බැලුවේ MRI එකට හොඳම කියන්නේ සම්පූර්ණයෙන් තියෙනවා නම් කියන්න පුළුවන් නේද? මොකයිද දැන් සම්පූර්ණයෙන් තියනවාද කියලා බලන්න ඕනේ. මම හිතන්නේ ඩොක්ටර් මගේ මේ ඔළුවේ එතනකින් මම පිළිකා ගෙඩියක් තියෙනවා. ඒකින්ද තමයි මේකෙත් වෙන්නේ. පිළිකා ගෙඩිය. හොඳට විශ්වාසද? මම හිතන්නේ ඔළුව වෙන්නේ පරීක්ෂණ කරනවා බෙහෙත් ගන්නවා කිසිම අඩුවක් නැහැ. ඒකින්ද මම හිතන්නේ මේ පිළිකා ගෙඩියක් තියෙනවා.
So as you can see, once again, it's headache. They are coming with headache. They are not telling all this at the start. And they are waiting for investigations to happen. And if it's not happening, they are pushing for more investigations. Because in the back of the mind, this young man thinks he has a brain cancer. Right? So there's repetitive and excessive health-related behaviors. And they scan their own body. So these are the things addressed when you do CBT. How they scan their own body and searching for information online. You need to address the hypochondriasis as we speak. And they seek reassurance, and the investigations only lead to temporary relief. As they say, CT එක කරාට පස්සේ හොඳයි, but it comes again. And some patients have no insight. They feel they don't have it but want to check. Some people are convinced they checked it. So the first thing in managing hypochondriasis is avoiding iatrogenic harm. The repeated testing is harmful, right? It is costly in most instances, and it keeps this sort of vicious cycle going on. So holding on to the patient and saying, no, we have done this, we will support you, and not doing the test. Repeated reassurance through testing is unhelpful and prolongs concerns. Appropriate investigation is needed, and you give regular appointments, but you don't give in to the patient's demands to do it. You're going down a slippery slope. The psychological management is the key here. The concept, their mind is catastrophizing. They are taking a headache and thinking of the worst case scenario, so they will need psychological support. If there is comorbid depression, and also if the symptom is delusional in nature, along with the SSRI, you can add an antipsychotic. So you will see in hypochondriasis versus somatoform disorders, the hypochondriac patient concentrates on an illness they think they have. The somatoform patient concentrates on a symptom, very similar, but the management differs. This is the last patient.
Good morning. Good morning, doctor. I'm Sachin University. Sachin Sachin is hospital.
This was an actual patient who came following very bad results in a term exam. right? So here in dissociation, they come with a involuntary disruption or disconnected. And the involuntary nature is what needs to happen here. You will notice that this patient is happy, right? The person trying to get out of the A levels and lying will cry and shout and act out. This is not. This is an unconscious mechanism, and unless we appreciate that this patient is not lying, you will, one thing, you will not be nice to the patient. Other thing is, you won't manage the patient. And to understand why such a thing can happen, if you just go into the psychology of it, what the girl is demonstrating is called labile indifference or a beautiful ignorance. So what happens is, she is pressurized by the parents to do the exam. She is worried. Her friends are getting higher marks than her. She has got 9 A's for the O-levels. Now she is very stressed, and that stress cannot be handled. Subconsciously, this stress is converted into a physical symptom, and thereby taking away the emotional distress. That is why they look happy but have a serious symptom. So this is known as primary gain, and we need to understand this concept if we are to be nice to the patient. Otherwise, you scold them, tell them, take them, and you keep them, they fall, right? And this happens sometimes when physicians are not too empathetic, right? So once again, give a positive diagnosis. There's nothing wrong. We tested everything. Provide a psychological explanation. Provide support with the stressor. Here, counseling is better. CBT has no major evidence. You need them to be able to cope. Young people struggle with coping a lot. Finding a nice counselor will be enough. They don't need a psychiatrist most of the time. If there is comorbid illness, they need antidepressants only. So, in summary, what do you not do when you get a patient with medically unexplained symptoms? Don't tell them they are fine. Don't tell them they don't have an illness. Don't accuse them of lying. Don't ask for unnecessary investigations. Don't prescribe antidepressants, psychosomatic, just don't give antidepressants. And don't think referring the patient might get more upset or they won't go. Yes, to refer to psychiatry is difficult sometimes, and some people will resist it, but having a consultant physician or a physician telling them this is psychiatric or psychological will be the start in their journey of getting better. They have gone, everybody is doing endoscopies, there is somebody saying, please go to somebody, and you have helped that patient. They might not go then, but they might go later. And it's okay to treat if there's clear-cut depression, but don't randomly treat without telling the patient. That is also wrong, because the patient has come to a physician or a neurologist, they look at them and they prescribe sertraline or amitriptyline or whatever, and in the patient's mind, okay, this physician has given me a medicine, right? This neurologist has given me a medicine. I have something physically wrong with me. So you're reconfirming their fears, right? I mean, a lot of physicians think, psychiatrists have 2-3 illnesses and 5 medicines and we prescribe it. Yes, it's a bit like that. So you'll think, Chathurie Suraweera fluoxetine dai, Sajivanta lewat sertraline dai, mama dekama dala yawannan, ethot tawat hondai, like that. It's a bit different, the referral. They will ask, is the husband drinking? What are the scholarship results of the child? What is happening in your life? How is your housing loan? If you have time to get into that, it's good. If you have time to refer to a psychologist, that's fine. Established depression, yes, anybody can treat. But when things are uncertain, when patients are presenting repeatedly, don't take that chance and refer. So you provide a positive diagnosis. Say you checked it. Give a reasonable explanation. Try to establish either yourself as someone as the single point of access so they don't go everywhere. A counselor, psychologist, psychiatrist should be in your everybody will have a cardiologist they refer to. Like that, you should have people you can send them to and provide regular structured care. So this is the algorithm. Is it depression? Is it anxiety? If not, these are the features. Look at the focus the patient is having and treat accordingly. And finally, the most important, if you want to take anything from this lecture, this is something I picked up from a lecture by Professor Chamara Wijesinghe, who said, the art of caring for the patient is caring for the person. So these are not just symptoms. These are just not illnesses. This is a person coming to you in distress. Treat them kindly. Treat them as a person, and the patient will benefit. And that is our sole role as physicians. Right? Thank you very much.
Thank you, Chamara Wijesinghe.
Thank you, Chamara. And we will take questions from all three speakers at the end of the presentations.
So after knowing the psychiatric disorder, masquerading as medical disorders, so then we will move on to the medical illnesses, masquerading as the psychiatric disorder. So this lecture will be delivered by Professor Arosha Sampath Dissanayake. Arosha Dissanayake is a professor and head of Department of Medicine at the University of Ruhuna and a consultant physician at the National Hospital Galle. He is a past president of the Ceylon College of Physicians and past president of the Galle Medical Association. He is a regional and international advisor of the Royal College of Physicians UK. He is also the international editor of Clinical Medicine, the Journal of Royal College of Physicians UK. His clinical and research interests include diabetes, toxicology, and medical humanities. He is an associate member of the Royal School of Music and co-founded the Southern Symposium and musical ensembles, which performs at medical concerts as well as conduct music for healing programs. He is also past finalist of the Chartered Institute of Management Accounts. He was an investigative journalist for the Sunday Times newspaper in his undergraduate days. Over to you, sir.
Thank you. At the outset, I wish to thank the President and the Council of the CCP for inviting me to give this talk, as well as thank the 17th century philosopher René Descartes for providing me with the opportunity to address you today. I am to speak about medical disorders masquerading as psychiatric disorders. I love storytelling. I tell a lot of stories when I teach the undergraduates. Somewhere along the way, I learned that the posh description for that process is narrative-based medicine. I will start with a story. I was like a first-year registrar in medicine when I got a call from the house officer saying, he was highly agitated. He said, there is a psychiatric patient who has been admitted to the medical ward, and that fellow is shouting the ward down. Can you please transfer this patient to the psychiatry ward? So then I said, okay. I was in the clinic. I made the fatal mistake of, not fatal, but a serious mistake of actually referring the patient to the psychiatry unit to take over without seeing the patient. Whilst in the clinic, my wife, some of you know my wife, she's a psychiatrist, she was a registrar in psychiatry. She called me about half an hour later and asked me, do you know that the patient you transferred to the psychiatry ward has a fever, a temperature of 105? I knew that things were not very good. I said, can you immediately transfer the patient back to the medical ward? And then I finished the clinic and I was walking towards the ward with my consultant at that time, the previous professor of medicine, Professor Lekam Vasam. We were walking down the corridor and I saw that a patient being kept taken in a chair with wheels to the ward, and obviously that was the patient coming from the psychiatry ward, and he was really shivering. He was shivering, he was shouting, but in addition to that, he was really shaking and shivering. And Professor Lekam Vasam pointed to the patient and said, whatever else you do, check for malarial parasites. He had falciparum malaria. So that is my introduction, the introduction I got into medical disorders. Of course, he had schizophrenia, diagnosed schizophrenia, that's why but suddenly he had become completely delirious, and that's where we missed the diagnosis. Without much harm, we managed to treat him and get him better. This is a landmark paper in psychiatry, done 50 years back, published 50 years back, looking at all the admissions to the emergency department, 600 admissions, and in 9% of the instances, the presentations for the psychiatric presentation were underlying medical causes. They looked at 600 patients who came with psychiatric symptoms to the emergency department, And nearly 10% had underlying medical disorders. And out of them, more than half were previously undiagnosed. This shows us the significance, how much of a problem psychiatric presentations could be towards the physician. Now, at times I wonder whether we've actually, the physicians and our training, whether we've got the hold of the wrong end of the handle. Now, when we study medicine, all the textbooks will read about SLE, will give all the clinical features of SLE, and then towards the very last bits of the SLE, perhaps at times even in small print, there will be all the psychiatric manifestations. So go from one corner to the other corner of Kumar and Clark or Oxford textbook of medicine. Under different diseases, you will find the psychiatric manifestations of the diseases, and we keep studying. And of course, I've just put a list here from some other source which I put together. Of course, this kind of list is also not available in textbooks, where they will give a list of all the medical conditions with the psychiatric manifestations. This is also very hard to find, but I put that. But if you look at that, you realize that it's so complex. No one can remember this. We study this, we learn this, but that's it. It's just too difficult for us to recall and remember. What happens in real life is patients do not come with the physical illness, but they will come with a psychiatric presentation. And then we need to work backwards from that to look for whether there is an underlying cause. So the paradigm shift that, that has been proposed, and I'm proposing to you today, is to adopt something like what happens with the toxidromes for poisoning. Now, for decades, we learned about all the poisons, digitalis to atropine to organophosphates to everything, and learned the clinical manifestations. Unfortunately, the patient is brought unconscious, he's very ill, dying. No one knows what poison has been taken, and you got to manage. And we were lost without knowing what the poison was, till we came up with the concept of toxidromes, where we look at what the patient's presentation and then work back what may have been the underlying poison and do what is necessary. So what is required is a similar approach to psychiatric, for medical illnesses masquerading as psychiatric disorders, where we look at some of the presentations, the psychiatric presentations, and then work backwards to see what may be causing this. And may I propose to you that we physicians familiarize ourselves with 6 psychiatric presentations: anxiety, depression, delirium, dementia, psychosis, mania, and be aware of what the medical illness possibilities could be. I've just very briefly looked at some of these. Of course, these lists are not exhaustive. You can add, something like neurosyphilis would come under any of these, but we hardly see neurosyphilis nowadays, so I've not written those things down. But anxiety and panic disorder, things like hyperthyroidism, they can come exactly like anxiety and panic due to so many reasons. Pheochromocytoma, notorious to miss. Certain tachyarrhythmias could come like that way. Hypoglycemia, well known. Very often, for everything we diagnose hypoglycemia and ask people to take sugar, but that's not the only cause. And then, of course, substance use as well as withdrawal. Withdrawal from benzodiazepines could come as anxiety. Methamphetamine use, etc. And things like multiple sclerosis could come with anxiety. So I've just put a list of medical disorders where the patient's presentation is anxiety or maybe panic attacks, and then we spare a thought to see whether there could be any of these underlying causes. Depression. Hypothyroidism is well recognized, so unless the psychiatrists will tell you they will diagnose so many patients with hypothyroidism at times who have been referred to the psychiatrist by the physician. And then, of course, Parkinson's disease could, one is they appear depressed when we look at it, or they could be having depression itself. Pancreatic carcinoma is a classic example of where patients come with depression and the underlying, and they lose weight, etc. So it could be this. And then even things like fibromyalgia can come with depression. Vitamin B12 deficiency can come simply with fatigue and tiredness, which looks like depression. Hypercalcemia, we know the triad of presentations of hypercalcemia, etc. So again, looking at a patient whom we think has depression, and then working us back to see whether there could be any of the underlying causes for depression. Dementia, hypothyroidism again, multiple cerebral infarctions. We know that the patient will need protective measures with aspirin, statins, etc. Normal pressure hydrocephalus, vitamin B12 deficiency, chronic alcohol use. People who are boxers, footballers, having traumatic, brain injury. And if somebody has pre-senile dementia, think about possible HIV as the underlying disorder. Could this be HIV? Again, a lot to think about. The patient who comes to the physician with depression, could this be an underlying disorder, medical disorder, presenting as depression? How about a psychosis? Complex partial seizures can come in the most strangest of presentations. Parkinson's disease again, psychosis with treatment especially. Brain tumors, limbic areas, etc. We know those may cause. SLE is well known to cause psychosis. There is this other story about this patient with SLE who stopped treatment after being well, and after some time, one day decided that he wanted to drive. He could drive. He knew how to drive very well. He had never driven a car before. He didn't have a driving license. Took the car, drove into a lamppost, and then that was the presentation of SLE. Wilson's disease is well known. Syphilis, I've written somewhere, I had to write syphilis among the psychiatric presentations because for those who are sitting exams, they still appear in MCQs, etc. But it's not a disorder that we see commonly, but it's well known. Mania, again a presentation of, could be Cushing's, hyperthyroidism, frontal lobe injuries, SLE, medications, steroids, we treat. Now, look at this combination. SLE can cause psychosis. Its treatment can cause psychosis. And both together are a potent combination for a patient to come with mania. Stimulants like amphetamine could come with mania. So that's the physician. Then, of course, some of you might wonder whether I wondered myself, and some of you may wonder whether I'm delivering this talk at the wrong symposium, at the wrong conference. You might say, look, if the patient has a psychiatric presentation, they will go to the psychiatrist, and the psychiatrist will realize that there is no underlying, that this is not a psychiatric illness, but this is due to a medical illness, and will ask the patient to go and meet a physician. It does sound simple. But that theory goes wrong in two instances. One is, physicians are the foot soldiers manning the front lines. And the casualty medical units and the emergency medical units are the places where all patients with illnesses which cannot be easily fitted into anywhere else are sent to. All physicians know this. If there's any patient who can't easily be fitted into something else, or if the psychiatry unit is not taking acute admissions, they will all be sent to the physicians. The second issue is, due to the prevalent, the stigma which is associated with psychiatric illnesses, families very often do not make a decision straight away to take their patient with what appears to be a psychiatric problem to the psychiatrist, but they might first bring the patient to a general practitioner or the physician that they know. And then the physician or the general practitioner need to be aware of underlying possible medical disorders which might cause this. And rather than just sending the patient to the psychiatry unit, look for the underlying causes and then try to manage those. So for those two reasons, it is extremely important that physicians be aware of medical disorders which can present with psychiatric presentations. This is my last story. I wanted to begin and end with stories. I had a patient. He had a lot of medical disorders, long-standing, and then, of course, the family said doesn't seem to be in a good mood, seems to be very thoughtful, seems to be down most of the time, not eating very well, not sleeping very well as well, and he's not really interested in things which are going on around him. So I sent him across to a psychiatry colleague of mine to assess for depression and treat if necessary. And I believe my friend started treatment. And then some time passed. I think the patient didn't go back to the psychiatry colleague. From what I can recall, I used to write the medicine in the prescription, the psychiatrist. So one day the family brought him, and then he sat near me. So I asked him how he was. We had a casual chat, and he said, "Doctor, I want to give you a gift." I mean, it is not unusual when patients like doctors, they give gifts. I usually get tea. I work in Gaul, you get nice quality tea, or somebody comes from Singharaja, they bring some nice treacle. That's the kind of gift I had received before. But this patient said, "Doctor, I want to gift you a Benz car." I mean, that sounded very nice. I have only a Toyota, and a fairly old one at that. I was thinking about it. Then he said, "Actually, I want to gift a Benz to the psychiatry doctor also." And that, I knew that things didn't sound all that well, 2 Benz cars. And then the family said, "Actually, doctor, we brought him because we had an alms giving at home and we invited 12 monks and he wanted us to bring 12 Benz cars for the 12 monks also." I looked at the prescription. He was on an antidepressant, so I immediately called my psychiatry colleague and said, "Can you please review him again? I think he's now turned into mania." So that was the story. The thing is, some of the medications that we give as physicians could actually precipitate psychiatric presentations. So that's the message from that story. So how do we find our way out of this labyrinth? I believe that one is we need a paradigm shift about the way that we learn and we teach medicine, the psychiatric aspects of medical practice, where we, rather than having the psychiatric manifestations of the physical disorders in small print in different pages in the textbooks, we need to look at, and we learn that and fail to apply, we need to look at the psychiatric presentations. I would say these 6 are probably the commonest psychiatric presentations that a physician is likely to encounter, and work backwards to see, learn what the underlying causes could be. So that's one. Second thing is, now, I mentioned René Descartes, the 17th century philosopher. He is at the beginning, I thanked him for making this lecture possible. He's the one who came up with this mind-body dualism in philosophy, where the mind and the body are operating completely independent of each other. And from there onwards, in many fields, including medicine, we had this mind-body dualism. The mind doctors are there, the body doctors are there, and we keep to our conclaves as such. Now, if you really look at the medical progress, we understand the biology and the molecular aspects of schizophrenia much more than we understand the biology and the molecular aspects of migraine, a very medical illness. So this medical dualism is actually coming to an end. And the challenge before us, the physicians and the psychiatrists, would be for the physicians to become better psychiatrists and the psychiatrists to become better physicians, so that we bridge this gap of dualism. Ideally, when this kind of patient is diagnosed, the physician should not simply hand over a delirious patient to the psychiatrist and ask him to arrange for lumbar punctures to see whether it's a meningoencephalitis. What is essential is that the physician treats the medical illness whilst seeking support from liaison psychiatrists to manage the clinical presentations and the behavioral problems that we are encountering. Thank you, ladies and gentlemen.
Thank you, Professor Arosha Dissanayake. Now the forum is open for the questions.
Yeah, I think the speakers kept to their times, but we are behind schedule, about 15 minutes overall. So let's limit to about 3 questions. Yes, there's somebody from behind. Can someone give him a... yeah,
Thank you very much for that all lectures, very informative. So my question is actually for Dr. Chathurie, and so there are in patients with major disabilities like stroke or spinal cord injuries, acquired brain injuries, or amputations. So the patients itself and the family undergoes huge amount of psychological stress. So as Dr. Chathurie explained, they are at high risk of getting depression. So we need to screen these patients. But sometimes their level of depressive symptoms are not severe enough for us to start antidepressant. But they need a lot of psychological input. So can you please elaborate what sort of provision currently exists within our system for this for the psychological support for this type of complex patients?
Very good question. At the moment, actually, like those who are undergoing a huge stress because of these conditions, ideally there should be counseling services, because it's not that they are having clinical depression as such, but they are like reacting to the life circumstances. At the moment, we don't have any services like that, but like depending on the services available in that particular hospital, like for example, we get those patients for our unit as liaison psychiatry referrals, but it all depends on the services and the human resources that you might have, because now we have a counselor who is qualified. Now most of the counselors who are saying that they are counselors, they are not actually qualified to tackle these kind of patients, because there are so many counseling courses, but that doesn't mean that they're really qualified, and particularly whether they are able to handle this kind of patients is a problem. And also with regards to psychologists, the government sector do not have psychologists at the moment, clinical psychologists. And we are trying to bring out the Cardiff by the college, but then like it has been like dragging on for a long time. So at the moment, some units, like for example, stroke units, burn units, with the collaboration with the psychiatry units, they are having certain level of services, but it needs to be improved quite a lot.
Just to add that, I think we have the card for psychology.
Yes, yeah,
Psychologist card is there. There's some issue with the recruitment, dispute over the pay, the salary scale. So that's we are trying to resolve that. Okay, thank you very much. Any other questions? There's somebody from the back, please. Can you?
Hello. Good afternoon. Thank you for the excellent talks. Just an anecdote to share of my own experience. So once we had a gentleman who was frankly psychotic, and was brought into the emergency department. And he was being treated with antipsychotics and sedated until someone took his blood pressure, and it was about 250 over 120, pulse rate was about 130. And of course, people were trying to say, well, actually, because he's psychotic, that's why his blood pressure is very high, that's why he's tachycardic, and because all the treatments he's had. But actually, he'd come from the airport, and he was a cocaine smuggler, and one of the packets inside him had burst. And he was frankly psychotic and tachycardic and hypertensive because he was actually about to die because of the other cocaine packets about to burst. We actually had to take him to the theatre to take out all the packets and save his life. So that was the most extreme case that I remember of psychosis presenting actually with a drug-related cause. My question is similar to this. So now if someone presents in the UK with psychosis, my psychiatry colleagues say, we're not going to even see them until you've excluded all the other medical or organic problems. So even frank psychosis now, they want you to exclude acute autoimmune encephalitis, do voltage-gated antibodies, MRI, LP, and then we'll come and see them, which is a real difficulty. And I don't know if that's what you're facing in Sri Lanka as well.
It depends on the unit, and it depends on where you are. But if it is frank psychosis and you have a psychiatry unit, the patient goes to the psychiatry unit unless it's very atypical. No history at all. There is a bit of a fever, sort of a chaotic sort of thinking pattern. And if the patient is not screaming and running around and is psychotic but handleable in the medical ward, we might ask them, this is the first presentation, it's a young girl, she's not going to hit anybody, why don't we exclude these things? But let's say it's a 25-year-old guy hitting people, tied up in a van, then it's sort of understood that this cannot be done in a medical ward. You take the patient over and you make the medical referral, and they come. But it is in units which don't have inpatient psychiatry units. This patient will be in the medical ward regardless and be managed by the physician and a psychiatry MO. And if they are frankly psychotic, they will need transfer. So it's a bit of a hybrid thing happening.
Okay. So, again, in my own experience, what's happening in my hospital now is the psychiatry wards have medics going into the psychiatry wards to actually look for people, a bit like the ones that Arosha were describing, to see if we're not missing underlying medical problems. So we actually have a dedicated team of physicians doing that now. So it's just something to share with you.
For us, it's when we refer only the center.
Okay. I think in the absence of any more questions, I would like to thank all the three speakers for their excellent presentations. And I think now I ask my colleague, Dr. Kumari Hami, to hand over the certificate to the first speaker, Dr. Chathurie Suraweera.